Good afternoon, everyone. We're going to go ahead and get started. Before we get started, I want to do two things in this order. Number one, see if Mr. Pugh has any announcements. And then number two, if anyone has any questions from our Monday and Tuesday session. And Mr. Pugh is still connecting to audio, so we will reverse the questions or that order. Does anyone have any questions on the last 2 days?
No, not really. But I do like the fact that it's on YouTube where I can check it out. Yeah, that was good.
Okay.
Yes.
That's good. All right, so what we are going to do first is play a game. And have any of you ever played a game called Kahoot? No? Okay. So first things first, the way that this game works is you have to have your cell phone out, because your cell phone will be the place where you will type in your answers, but in the Zoom window is where you will see the questions. So let me pull up my screen here. Okay, so on your cell phone, go to the website Kahoot It. And once you get there, you're going to enter what is known as a game pin. And again, you're doing all of this on your cell phone. And I should have mentioned this, but I will tell you for next time. Please make sure that you put in your first and last name so that we can identify who you are. But again, on your phone, go to this website and then key in the PIN number. And then in the Zoom room is where you're going to see the questions once we get the game started. And because this is new for some of you, we're going to allow just a little time for you to get logged in. And I'm going to compare the participant list to the list that is on the screen here. And so again, thank you, Laretha Edwards, for following my instructions. So next time, everyone, first and last name, your full first and last name, so that if I need to run a report, I'm not having to figure out who is who. So first and last name. And we got some more folks joining, so we will wait a second. So again, for those of you who are just joining us, we are going to be playing a game for the first part of our course. And for this game, you're going to log on to the website Kahoot It on your cell phone, because your cell phone will be like your game controller, if you will. And then in the Zoom room on your computer, you're going to see the questions once we get started. So let's see. Let me check the roster against the names. And again, for those who are just joining, I will repeat again. We are going to be playing a game. And Your cell phone will act as your controller to answer the questions, and then you will see the questions appear on the screen. When you answer the questions on your phone, they're going to be color coded, and the color coded option choices will be what you will see on your Zoom screen. So when the question first appears on the Zoom screen, you won't see the 4 answers. And then after that, you will use your phone to actually, and Mr. Pugh, first and last name, put in Mr. Pugh. And we still have some people joining. And I wanted to take this time to get you all acclimated to this system because we are going to be using it. And so for those that are just joining, we are going to be playing a game. And this game is played with your cell phone, which will be your game controller. And then your Zoom window will be where you will see the questions and then the answers. The answers are color coded. And so what's going to happen is on your phone, you will click the color that you want to select as the answer. Once we get to the first question, I think it will be clearer. And each question you will have 60 seconds to answer. And so we will just wait a few minutes for those that need to get logged in. So there are, somebody just left. 1, 2. So again, when you enter the game, please put in your first and last name. So let me see who we're missing as it relates to the game. So Henderson, Pugh. There's a Ariana who has not logged into the game yet. So if you could please log in. Let's see, Harrison. I don't see Jenkins. Also, if you could update your name in Zoom so that I can see your first and last name. And let me rephrase that. Your full first name and your full last name. So for example, Laretha Edwards is the exact model that we're looking for. All right, so we had somebody jump in and jump out. So let me just pause for a second. And we are going to start that process all over again so that everybody can put in their full first name and last name. It will be a new PIN number. Let's just wait 1 second for everyone to join. And again, could you please rename yourself in the Zoom room? So if you don't know how to do that, if you click on your name on the roster, you should see a link for, I think it's more, and then you can rename yourself so that it is your first and last name. Mr. Pugh, you don't have to do it. I changed Mr. Pugh's name. Okay, so I'm going to relaunch the game, and there's going to be a new PIN number. And this is our practice session. This is so that we can have a flow for every time we have the game. So for those of you who are joining, 1 second. You're going to start over, and Use the PIN number and your first and last name.
I'm sorry, my computer was acting really crazy, so I need to know, what are we doing?
All right, so we are about to play a game. And in order to play this game, you need your cell phone and your computer. Your computer will actually display at some point the game with the question and then 4 multiple choice answers. The multiple choice answers are going to be color coded. You will use your phone to click on whatever color you want to select, which relates to that answer. To get started on your phone, you are going to go to Kahoot It and then type in the game PIN.
Okay, thank you.
All right, let me do a check here. 1, 2. All right, we are ready to go. I gotta turn that music off because it works my nerves. All right, so it's like boom, 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 boom. So what's gonna happen, once I select start, the question will appear in the Zoom screen. Once the question comes across the top, the questions will then immediately follow, or the answers. The answers will have words and colors. On your device, you're gonna hit the color that you want to select. You will only have 60 seconds to answer each question, and something just happened on the screen, so let me see what happened. So while I have a question because I don't know this answer. While you're in the game, are you able to change your name? Like right now, can you change your name, or do you have to log out and come back in?
Yeah, you have to log out and come back in, and when you do, it don't let you. Because that's what I tried to do to change my, fix my last name, and it told me it was already taken, so it won't let me redo it.
Okay, so for next time or the next game, you'll know how to do it the first time. Okay, so why do I feel like we lost somebody? 1, 2. All right, so we are going to go. I'm gonna mute myself so that you don't get any background noise, and here we go. All right. So the one thing that you will want to know is that this system is kind of competitive. And on the next screen, it's going to display points. And the way that the points are calculated is number one, how fast your finger is at hitting the answer and the correct answer. And that's how you'll see on the next screen your names and the points. And also, the correct answer is going to have a check mark by it. So if for some reason you got this question wrong, now you know that the answer is medical coding. Additionally, if for some reason you are unable to attend class, we are recording all of our sessions. And so the recording will be via the link that I sent maybe 2 days ago. And something else I want to tell you. If you miss, it's very important that you watch that recording before you come to the next day so that you won't be confused or behind. All right, next. Uh-oh, Mr. Pugh kicking y'all in the butt. Hey, let me tell you something funny. If Mr. Pugh don't get 100 on these questions, I don't know what he been doing the last, I don't know how many times, how long we've been doing this program. But Mr. Pugh should know all of these answers. I put him on the spot now. All right, here we go again. This is something that we talked about yesterday. And that should say coding system. I think I had to delete some of the words in order for it to fit on the screen. All right. Well, there are no losers in this game, right? Because everybody is here to get education. But one of the reasons that I did that in this format is because when you are taking your CMAA exam, you're going to be on a computer. The questions are going to come up for multiple choice answers. It won't be a team test, but you see how important it is that you know the information. So as we continue down this journey, what do you plan to do to ensure that you understand the information that you can apply it?
I'm gonna take better notes.
And okay, so now better notes. Keep in mind it's recorded. So I think sometimes some people do this. Just trying to write all of these notes, but you're not absorbing the key aspects of the conversation. And so that's another reason why I record it, because you can't write down everything I say, everything that's on the screen, kind of do bullet points, and then you can listen to the recording to fill in the gaps of the content or something else that you may want to write down or something else that you needed to, redo, if you will. Somebody else.
Study more.
Okay.
I know for me, I wasn't able to attend the class yesterday, so I missed basically everything on the quiz. I got a few right, but just reviewing the material, looking at the recording. So that's definitely important to do, even if you don't miss it.
All right, sounds good. Anybody else?
It's more of a passive thing, I guess, but I do like listening to recording on the background. So like when I'm doing something else, I'm listening to you talk and I reabsorb the information. So yeah.
Okay. All right. So now that we have everyone here, I want to ask a question that I asked at the beginning. Again, is there something from our first or second session that you don't understand so that I can clarify the information before we jump into today?
No, I don't have anything.
All right, well, I am going to load up our content for today. So give me 1 second because I am trying to not have 10 million screens open because I don't want my computer to crash on me. I had like 20 windows open and my computer started acting funny. And I'm like, this is an Apple. It's supposed to be able to handle 20 windows open at one time. And I'm one of those people who I am a Windows user. And I had this Apple desktop and I didn't really have the patience to learn how to really use it. And the pandemic afforded me an opportunity to use it. And I love it. I'm like, no more Windows computers for me because I am now Team Apple. For many reasons. One, like I could be working on something on this computer and pull it up on another computer or my iPad or something like that. So I am definitely I'm definitely a fan now. At first I wasn't, because even the mouse scrolls differently. But I am a person who is okay with dealing with change. And so, all right, so today we are going to go to domain number 3, which focuses on office logistics. I want to reiterate something that I said yesterday, and that is, if you currently work or have previously worked for a healthcare organization, you really want to ensure that you answer these questions based on how I'm presenting the content, because the exam was not written based on what you do at your job. And you will find some things that you'll say, well, we don't do it that way. And the question is, are you doing it the right way, or is that just the way that your organization does it? All right, so the first thing we're going to talk about today is how medical records are filed. So yesterday, towards the end, we talked a little bit about retrieving charts, filing charts, and so like active and all of that. So today we're going to look at office logistics, and the first area is how we file medical records. And again, let me give this disclaimer. On this exam, you're going to see that they talk a lot about the paper world, because the electronic world is not something that everybody has. So they talk about both. So when we talk about filing systems, there are 3 main types that the NHA wants you to know. Number 1, we can file medical records in alphabetical order by name, or we can file them alphabetical order with a color coding process. Then we have the systems that I personally love to hate, which is the numeric filing system, because you thought everybody didn't know their ABCs. Apparently, people don't know how to do numbers either, and you will see why shortly. So as it relates to numeric systems, we can file numbers in what is known as straight numeric orders. So let's say you have a medical record number 1, 2, 3, 4, 5, 6. It would be filed just like that. But then we have this other system. I hate the system. It's called terminal digit filing. And with terminal digit filing, the word terminal means what?
It means end.
The end, yes. So with terminal digit filing, in my example of 1, 2, 3, 4, 5, 6, you would start with 5, 6. Now, for most people, your eyeballs do like this double take, like, what? I got to go here instead of going over here. And so yes, okay. So with terminal digit filing, we start from right to left, as opposed to straight left to right in terms of how we read the numbers. And you're going to have some examples in a minute. The third type is called the middle digit. And just as the name implies, we start with the numbers in the middle. So we do the middle, and then we go to the left, and then we go to the right. I know, crazy. Also with numeric, the numeric system could also be color coded. And I was thinking I had a file sitting in front of me. Oh, kind of, sort of. So you know how you have different color files. And so each color represents a particular set of numbers. And so again, when we're reading, and these are not medical records, these are just file folders empty right now. When we're reading it, we go and look at the number. And if we're doing straight numeric, left to right, 1, 2, 3, 4, 5, 6. If we're doing terminal digit, 5, 6, 3, 4, 1, 2. If we're doing middle, 3, 4, 1, 2. I see some heads shaking like, really? So funny story. When I was working in the office, I got to put these up. When I was working in the office as a medical assistant, I would never forget this. I was working at Northwestern Medical Faculty Foundation. And one day, the people from I was in Norridge by O'Hare Airport. The people from downtown came out to Norridge, like some of the big wigs. They came in that day and fired the office manager, several of the people at the front desk, and the medical records person. And basically left me, the medical assistant, a nurse, and then one front desk person. So they were like, basically, the nurse and I would have to do more administrative work. So for me, it wasn't a big deal because even though I was a medical assistant at the time, I was in that role primarily focusing on being in the room with the provider. Some days I was working with an OBGYN, so I would have to assist them with the pap smears and minor procedures that they were doing. Another day, the pediatrician was there, so I was giving the kids their vaccinations. I was drawing blood, I was collecting stool samples, urine. And then another day, or half a day, because sometimes it would be split, the internal medicine doctor would be there. So I would be doing my thing in the back. And so they were basically like, yeah, you two, you're front, middle, and back. Well, for me, I was like, no big deal, except when it came to those medical records. I did not want to do anything with those medical records. And at the time, they had this terminal digit filing system. I was in this room so mad trying to find these records because I was like, what order are these numbers going in? And then there was also something that I hated, which was these loose files. So I would have this big stack of medical records and a big stack of papers, and I would have to look at each report, see whose name it is, whatever the medical record number is, and put it into the chart. I was like, oh, this is not for me. I told that nurse, I said, I'm just gonna tell you about me. I'm gonna be up out of here because I'm not trying to do all of this because they didn't give us any more money, but they wanted us to do all these extra responsibilities. So in that setting, I actually learned this on the job. And then thankfully, they, before I left, because I did leave, I was serious about that. First of all, I was coming from the South Side, going all the way to O'Hare Airport. So I wasn't making a whole lot of money. This was in the 90s. I wasn't making a whole lot of money, but I was spending gas money. I was in all that traffic, which will send you to a place. And so they implemented this system where it was like a barcode. And I was like, that's doable because you just had to scan the little barcode on the chart, and that was much better. But I have more nightmares to tell you about, or could tell you, but I'm not going to tell you because I don't want to scare you. But luckily, we don't have as many paper charts today. But we still have organizations that have paper charts, and several of them are willing to pay a penalty to the government for not having the paper charts because they don't want to deal with the computer. And then the third type that you're going to see is not really related to medical records, but more related to the business side of the physician office. And that's where we're going to file things like any type of business records, invoices. So like bills, cable bill, phone bill, we would file those in that particular area. Any letters, correspondence, we would file that there. All right, so we are going to do an exercise with organizing these numbers using the middle digit filing system. And to review with middle digit, it's the 2 in the middle, the 2 on the left, and then the last 2. That's how you actually going to rewrite them. So for example, if you just isolate the middle only, I got to draw a line so I can just have my eyeballs zero in. Which chart is going to go first in this sequence?
Top chart looks like it would still be first.
Yeah, the first one.
So it would be 0, 0, 0, 5, and then 7, 5. Then what would be second? This is where it gets tricky because you got 3 that have the same number at the beginning.
So it would be the 0, 5,
The 0, 5.
35.
Right. 0, 5,
28.
35, 28.
0, 5, 35, 28. Then
0, 5,
5, 7, 8,
78,
7, 8,
28,
28.
and then
80,
0,
0,
5,
5,
87,
87,
28.
28.
Miss Smith worked at counting, and back in the day, we used to have those records stacked up to the ceiling.
Yeah.
They probably still got a few papers floating around.
Oh, yeah, they surely do.
Okay, so now that we've got the process started, take a few moments, organize the numbers, and then we'll get a volunteer, not Miss Smith, because she has an unfair advantage as an RHIA. So Miss Smith will be the fact checker. So
Okay.
whoever's gonna go first, Miss Smith's gonna check the facts and see if you're right. And for purposes of this recording, I'm going to pause so that we don't have this dead space on the recording. All right.
All right. So I have 0, 0, 0, 5, 7, 5, 0, 5, 3, 5, 2, 8, 0, 5, 7, 8, 2, 8, 0, 5, 8, 7, 2, 8, 1, 3, 2, 5, 7, 5, 1, 3, 2, 7, 7, 5, 1, 3, 2, 9, 7, 5, 8, 7, 0, 0, 1, 6, 8, 9, 0, 0, 1, 6, and 9, 0, 0, 1, 1, 5.
All right. Where are my fact checkers? I know there's going to be more than one fact checker than the one that I assigned.
Yeah,
Miss
that's,
Smith.
that's what I had
She's
too.
correct.
That's correct.
Yep.
All right. Sorry, my lunch it's a little frozen. All right. So that wasn't too bad, right?
Mm-mm.
All right. Now, that was the reason why I did that one first. So we can go over to this one now. Terminal digit. So again, with terminal digit, I think of it, the records are filed backwards, really, because you are starting with you're going from right to left instead of left to right. So I will pause again and we'll take another volunteer to give us what they think. Anybody ready?
I want to try. I don't know if I did it right.
Okay, wait 1 second. Let me get the recording back on, and we got to get the fact checkers that are ready. Some people are brave and will go, and other people are the fact checkers, which is fine. Oh, and actually, it looks like I'm still recording. So sorry about the dead space on the recording.
Okay, I'm gonna go ahead. 150190. I don't know if it should have been the opposite way.
Fifth, so right to left. So 159001.
Okay, so all of them I screwed them up. So it should be, the next one is 168700. Then I got 168900. Then I got 280535. Then 280578. Then 280587. Then I have 750005. Then I have 751325, 751327, and 751329.
Fact checkers?
You're right.
That's
Yeah, that's
correct. But I have a question.
Mm-hmm.
On the test, how will we see it written? Would it be written like this, or will we have to write it the way she just stated it?
So honestly, I don't know, and I haven't seen the test.
Okay.
So I don't know if you'll even get this question, but it is
okay.
part of the things you are supposed to know. And you guys will be put into these review modules at some point, and there will be practice questions. And then if you see one on there, you'll see what it looks like.
Okay.
All right.
Thank you.
Okay, so that was fun, right? So now you guys see why I wasn't really a fan of of medical records. It wasn't my thing. All right, so next up, we're going to look at organizing charts. And in terms of organizing charts, generally, when we're talking about, again, this file folder system, there's different ways to do it. Some organizations will organize it by source. So all of the lab tests go together. All of the progress notes, for example, would go together. So I am going to show you an inpatient record just to start off, because this the inpatient record is a little larger. So we'll just wait 1 second for it to open up. And one of the reasons that I'm showing you this inpatient record is because I mentioned to you that, okay, oh, there I go. I mentioned to you that you may not see a job posted for certified medical administrative assistant, but you may see a job posted for patient access or other areas that we've talked about. And so I want to make sure that during our journey, we don't just focus on what NHA wants you to know. We want you to see things outside of that. So this is an inpatient medical record. It is a typed medical record. It's not handwritten, so don't worry about that. I do got some handwritten ones, but we have to take some aspirin before we, or some Norco or something before we look at a handwritten note. All right, so the first page that you're looking at is known as a face sheet. And think of this as the demographic information that we talked about yesterday that is collected when the patient registers for that service. Now, it is very important that the person who does this registration process ensure that the information is accurate, because if we need to send the patient a bill or if we need to call the patient, we need to have the correct information. This record itself is probably about 40 years old. And so it's something that we use for educational purposes to make sure we don't violate any HIPAA. And so it actually has been recreated, if you will, but it is a real patient. So the face sheet is created by the registration department. And one of the common mistakes that the registration patient access people do is ask the patient. So let's say I'm looking at this screen and you're standing in front of me and you're the patient. And I say to you, welcome to Global Care Medical Center. And then you tell me who you are. I get a copy of your ID, the front and the back. And then I say to you, has anything changed? Well, that's a problem. I'm looking at the screen. You looking at me. You don't know what I got. So asking somebody, has anything changed? You're like, nope. You don't think, hey, I got a new phone number, or I moved, or something could be wrong in the system. For example, when I got married, I got on my husband's insurance, and somebody at the hospital that I go to changed my last name during one of my visits. And so I went to the emergency room. That's where I was going. They printed out the sheet to have me sign it. And they said, check it over to make sure everything is okay. So I look at it and it has my first name and my husband's last name. And so I said to the insurance, the patient access person, I said, that's not my last name. And she says, well, on your insurance card, it says you're insured under this person. So that is your last name, the same name as that person. And I'm like, no, because when I got married, I was full grown, growner than grown, and I didn't change my name because in this industry, people know me as Campbell. So I was rolling out with Campbell. So I think she might have been the one that changed it. And I stood there in full-blown asthma problem saying, I need you to change my name because that's not what my name is. So it is really important that we let the patient confirm that all of this information is correct. Also, it's very important that we get the patient's emergency contact, because in the case of an emergency, we need to know who we should actually contact. Then on this face sheet, you see other information like the admitting diagnosis, something else called the principal diagnosis, something else called secondary diagnosis. Uh-oh, I got a question. What is the name of the coding system that is used to assign diagnosis codes?
ICD-10.
ICD-10.
CM.
CM. Don't forget that CM part. All right. So that's the face sheet. After that, we have a consent for admission. And it's a consent for admission, but it's some other stuff. And I hate when you get registered and they say something like, this is just for us to treat you. Sign here and sign here. But no, this is not just for you to treat me. If you look at this form, it's actually got two parts to it. the top part is about consent to treatment. And a lot of times in this form, if you go to a teaching hospital, they'll slide in there that you agree to be seen by the residents and all of that. But if you look at the bottom of the form, it's consent to release information for reimbursement purposes. So this is where the patient agrees that we can release their medical record for payment. So remember, under HIPAA, we use medical records for treatment, payment, and operation. So this is where the patient is agreeing that we can do this. Then we have advanced directive, and we talked about this yesterday. This is where we have on file all of the patient's wishes. And because this is not a medical records coding class, I'm gonna be zipping through these forms. Every time we do this class, people say, oh, I think I wanna be a medical coder. So, but that's not why we're here. We're here for this right now, one thing at a time. So this is a discharge summary. And a discharge summary is just a synopsis of the patient's stay. Some doctors are a little bit more thorough when they do their discharge summaries. Some don't even do them at all. We got to chase them down. I bet you Ms. Smith could share some stories with you about that would cause us all to gasp for air. But this is where they summarize, the hospital stay. So on the first page, you kind of saw some diagnoses listed, but if I were the medical coder coding this case, I could not look at what the patient access person put in because it may or may not be correct. The other thing that you should notice is that this medical record has some medical terms. So you learned about prefixes and suffixes and word roots and all of that. And so this patient has acute pyelonephritis, which is inflammation of the renal pelvis. And then from there, you just get this summary about the hospital stay, labs, and other things that they did. All right, and this person was also dehydrated, so they gave them some fluids. They had some urinary problems, and so they put them on some antibiotics. All right, after that, you see one of the very first documents that is generated during a hospital stay, and it's the history and physical exam. Now, with a history and physical exam, you're going to see essentially 3 parts: talking, touching, and thinking. So I'm going to divide this note up, and the very first part is pretty much the talking, and all of the talking ends here. So the first part, they go over the admission diagnoses, and then from there, they go into a chief complaint. Chief complaint is what the patient says in their own words is what's wrong with them. They don't say, I've had 5 days of rhinorrhea, right? Rhea, discharge, rhino, nose. They don't say that. They just say, I feel lousy for the last 5 days. I got chills and fever. Then after that, you see what is known as the history of present illness. And this is where we get a little insight into how long they've had the problem, what's associated with the problem, what they've done to make the problem better or worse. So if you got a fever, you're taking aspirin, that's what you see there. From there, they go into past family and social history. And because this person was admitted to the hospital, most of the past family social history is related to the problem that the patient is here for, because everything in their history is not necessarily important for today's hospital stay. But the goal of admission to the hospital is discharge. It's not for you to stay there, kick back, smoke cigarettes, kick your feet up, have the nice gown and the little bucket with the soap and the lotion. The goal is for you to go home, for you to get better. So after that, you see review of systems. Review of systems is still the talking part. It's not where they're asking the patient, it's not where they're touching the patient. So it's really where they're asking the patient, do you have or have you had XYZ problem? And they usually do it by system, which is why they call it review of systems, but they're not touching the patient. So essentially what's happening is that they are trying to confirm or eliminate what is and what isn't going on. So after that, and let me erase this line, this is where the touching begins, and this is the physical exam. And in this particular case, what you're going to see is that they are examining only those systems or body parts that are related to why the patient is there. When you are admitted to the hospital, they're not solving all your problems. They solving the problem or problems that require intense healthcare services, and the rest of that stuff can be treated on an outpatient. So they're working on the problems that are really those that you need an IV in your arm, you need intensive monitoring, things that you can do at home. So what you will see in the medical record is that they'll start off with all these IVs, and very slowly they're transitioning them to oral medication so that they can go home. So after that, you see the progress notes. And usually when the patient is admitted to the hospital, there are daily progress notes, because again, what's the goal of admission? Discharge. Progress notes are generally written in a format that is called SOAP. And so the visit on the 29th is a great example. And let me just highlight subjective, objective, assessment, and then the plan. So the subjective is basically what the patient is saying, so to speak. Objective is what the provider confirms, observes, etc. Assessment is what the problem is, and the plan is what they plan to do about it. So probable left pyelonephritis, rule out stone, positive streptococcal bacteremia, possibly secondary to pyelonephritis, possibly other source, abscess, doubt. And then intravenous pyelogram is okay. And what they're saying is they had an intravenous pyelogram and it was okay. So after that, let me erase this and kind of just look at some of the other stuff that's in here at the top. So you are consistently seeing things that you already know. We already know from the discharge summary that they had the pyelonephritis. We know that they had some type of infection. And so what you see is they're dehydrated. We're rehydrating them. They got some type of infection. How do we know? Because they got a fever. So they gave them Ancef. Ancef is an antibiotic. And so again, they're solving the problems or treating the problems that the patient has, not necessarily everything that they have. So then after that, they talk about there is an alpha strep in the blood culture, not viridians, and then they just keep going on and on. And then after that, you see the orders. So every day when the provider comes to see the patient, they will write orders. And these orders are what the nursing staff is going to carry out, or other people, lab, radiology. And so what you're going to see is that the doctor will do all of these orders, and then the nurse, who is the licensed professional, is going to make sure that all of these things are carried out. So you're seeing blood work, EKGs, chest x-rays, They want them to give them Tylenol. They want them to just monitor them, all of that. And then each day you see something different. And eventually you see that they are discontinuing the IV fluids because now the patient is no longer dehydrated. They're switching them from the IV Ancef to an oral antibiotic, which is Keflex. And then after that, you see they got kicked out. All right. So then you got all the laboratory results. And so all of the results that you saw earlier in the test, these are the actual reports themselves. And so what you should notice is that they're organized, they're grouped together based on the type. So this is our urine results. Then we have blood cultures. The patient had an infection, so they are collecting the blood cultures because they need to know which antibiotics are going to work for the problem that the patient has. Usually what happens when a patient gets admitted to the hospital, they give them what are known as broad spectrum antibiotics. It's kind of the ones that will try to kill anything. But then once they get the blood cultures back, they will find out which specific ones work for the problem that the patient actually has. Additionally, one of the reasons that they do that history up front is because they may discover that this particular class of antibiotics will work for a patient, but maybe that patient is allergic to that particular class of family of antibiotics and they got to find something else. So that's what all this stuff is. Then after that, more blood cultures and now blood work. So they're looking at, the patient's electrolytes, they're looking at their sugar and all the other elements that they can check for. And this is a urine culture because in the discharge summary, they talked about the patient having some type of urinary problem. And in the note here, it grew E. coli. So after that, we got a complete blood count. That's the white blood cells and the red blood cells. And when somebody has an infection, the white blood cells go in and start to attack because they're trying to fight off the infection. Kind of like people said, like with the COVID vaccine, some people with their second vaccine had a fever and chills. Why? Because the body went into attack mode because it was something that was foreign. My husband and I have a running joke in our house because we both had our first and second vaccine at the same time. The second one, I got me a good old day of rest because I had fever, chills, and all of that. My husband had nothing. So our running joke is my immune system is better than yours because mine got in and started fighting. You went on with business as usual. But that's the whole purpose of the white blood cells and the immune system. Then you have this radiology report. And then after that, and we know that the patient had the intravenous pyelogram because they mentioned it earlier. And this is where they say that it is normal. After that, they had an EKG. So here's the little EKG rhythm strip and the findings. After that, we have what's known as a graphic sheet or a flow sheet. And what the flow sheet is where we capture the vital signs, so pulse, temperature, respiration, blood pressure. But we can also look at what the patient takes in and what they put out. So for example, if you have somebody who is having difficulty urinating and we are pumping them up with fluids and that those fluids are not coming out, that means that the fluid is backed up in the body and they need to figure out why, because the whole purpose of your urinary system is to get rid of waste. So they're measuring, this is how much we put in, this is how much they put out. And it can be urine, it can be stool, all of that. And then because patients' vital signs are monitored, every shift or every time frame as specified by the doctor in the orders, then you just continue to see more data. Because the nurses are administering medications, you will see a medication administration record. And so here, the medications that we saw earlier, now you see that they were given, who they were given by. And so one of the things that some professionals do in healthcare, in the medical records department, is that they look through these forms to make sure that everything coincides. So if we saw an order for ANSEF, we should see that the ANSEF was given. If the patient had an IV inserted, we should see that the IV was discontinued. I see lots of records where it appears the patient went home with the IV. I don't know how that works, but they went home, according to the paper, they went home with the IV in their arm. More than likely it was discontinued, but it wasn't documented. And there is a golden rule. If it wasn't documented, it didn't happen. All right, so more medication administration record. In the electronic world, we call this the electronic medication administration record. In the paper record, we call it the MAR. And then you see all the nurses at the bottom who actually gave the medications. After that, we have our IV therapy record. And this patient, luckily, their IV was discontinued. And the nurse noted in the bottom right-hand corner that the needle was removed intact and that there is no signs of redness or inflammation, infiltration at that site. And that's important because if we put the needle in, the whole needle should come back out. We don't want that needle stuck in the patient's arm. After that, this is some administrative stuff. If somebody gives us any personal valuables, money, all of that. Then we have the nurse's notes. And the nurse is basically documenting everything that they did during their shift. And more nurse's notes. And more nurse's notes. And more nurses' notes. Now you know who does all the work. Nurses rock because they do all the work. All right, more nurses' notes. And then the patient is out of there. All right, so that was an example of how an inpatient record is organized. And in the physician office setting, you're going to see something that is very similar. All right, so before we move forward from organizing charts, do we need a 5-minute bathroom break? Caffeine break or any other type of break?
Okay, I need caffeine.
Okay, 5 minutes. I'm gonna put my clock on or my timer. So we just talked about organizing charts, and on some occasions, there are, wait 1 second because my screen looks funny. There are situations where the portions of the medical record has to actually be scanned into the system. And so things that could be scanned are photos, illustrations, and we talked about this yesterday, but it's a pretty, generally powerful system that can do double-sided, color, all of that. All right, and that is a piece of equipment that the CMAA should be familiar with what it is and what it does. Because we're talking about office logistics, we are going to see this picture again that shows the difference between the EMR versus the EHR. And generally speaking, the EMR is isolated to a single healthcare organization, whereas an EHR should have the ability to be accessed by more than one organization. You'll see that some health systems will have EHRs, and you could be in a totally different location and have access to records. That was the whole reason that electronic health workers were established in the first place, so that we can see them outside of those four walls. And I will tell you that for the work that I do it for organizations that are not even in Chicago, and I access their system remotely via the internet. All right, the next part of office logistics looks at the money. We talked a little bit about the money yesterday, but one of the things that you'll find with these domains, information kind of crosses over and repeats over and over again. Speaking of repeating, 4 terms that you need to know as it relates to health insurance: premium, deductible, co-payment, and co-insurance. Who wants to tell us what the premium is? Everybody's like, not me.
A small amount, a dollar amount that is paid to activate or keep the insurance.
Yes. So who has ever heard of Obamacare?
Everybody?
Well, some people, I feel like they've been under a rock and haven't heard about anything, but which is probably good because there's so much bad stuff going on. But with Obamacare, you could go to the marketplace and you could select a plan. And the plan was usually, the offerings were like gold, silver, platinum, bronze, right? And the differences in them, there were many. One, the premium varied based upon the program that you selected or the plan that you selected. And a lot of people take employer-sponsored insurance for granted. And I'm going to let Mr. Pugh tell a story in a second. So when you work for an organization, they pay a portion of the premium, and then you pay a portion, through payroll deduction, right? And so the two monies together is what pays your premium. But if you stop working for an organization, they will give you a certificate of coverage and will tell you that you can sign up for COBRA. All right, Mr. Pugh, that was your lead in to tell your story about COBRA. Let's see if Mr. Pugh's still there. Well, anybody else got a story to share about COBRA? I'll tell you Mr. Pugh's story.
Do they fight G.I. Joe?
No. So COBRA, guess I won't be able to chew my gum either. I thought Mr. Pugh was going to tell his story while I chew my gum. So with COBRA, instead of your employer paying a portion and you paying a portion, because you no longer work there, you pay it all. That is similar to what Obamacare was like, because you had to pay that premium. And I remember my mother, she retired from her job, but she wasn't old enough for Social Security, so she had to get Obamacare. And it was about $700 or $800 a month. And that's this kind of the similar situation that Mr. Pugh talked about, which was when he went or was attempting to go on COBRA, how much it costs per month for him and I think his wife was upwards of $800 a month. That's just the premium to keep the plan going. But then on top of that, depending on how much you pay in a premium will coincide with what your annual deductible is. And that's the amount that you pay before they pay. So you paying the premium and the deductible before they do anything, because they're covering you, right? They're assuming the risk. Then you have the co-payment versus the co-insurance. Co-payment, small fixed amount. And on that little game, I put small fixed amount for a service or for a medication, because we have medication co-payments as well. And generally, they are, the insurer will have what's known as a formulary. And the formulary will be divided into 3 tiers. So it's like tier 1, 2, and 3. So tier 1, you may pay a $10 copay. Tier 2, you may pay a $30 copay. Tier 3, you may pay a $40 copay. So whatever tier your medication is that your doctor prescribes will determine what your copay is. So if you have insurance and you're like, well, why I gotta pay $5 for this one, but for this one, I have to pay the other dollar amount, and that relates to what tier that medication is in. And a lot of people don't realize this. When you sign up for insurance, they give you all this information in the packet, and you just say, oh, I'm gonna put that to the side. I got my insurance card, so I'm covered. But then once we verify your insurance, we learn, yeah, you got that card. However, your insurance covers this, but you need this. And so you will have to pay for whatever your insurance doesn't pay. Now, co-insurance, that's that small fixed amount. And with the co-payment, if we take an insurance company like Medicare, Medicare has 4 different parts, which we'll talk about another day, but Part B is for physician services. And with Medicare Part B, Medicare will pay 80% of what Medicare allows, and then the patient pays 20%. Medicare does not care what we charge. They only allow a certain dollar amount for every CPT code and for every HCPCS code. They only allow a certain dollar amount. So if a physician chooses to participate in the Medicare program, they accept assignment. And what that means is they accept what Medicare pays them as payment in full, and they write off the rest of that money. So because I'm a visual person, and I'm sure many of you are as well, let's look at a math problem. So here's a situation where Dr. Smith is a par physician, par meaning participating, and the patient is treated by Dr. Smith in the office, and the doctor charges $50. $40 is what Medicare allows. Dr. Smith collects $8 from the patient and is reimbursed a total of $40, which means Medicare is paying $32, the patient pays $8, you add those two together, carry the 1, and that's $40. That's old school math for the young folks, carry the 1. All right, so, and then the $10, the difference between what the provider charged and what Medicare allows is $10, and they write that off in the system. Make sense? Okay. I'm going with the head nods because not everybody's on camera. All right, so in our systems, our computerized systems, we have different ways of capturing patient payments, patient services. So here we're going to look at an example. Let me draw my box. All right, so on April 5th, we entered a charge for our patient for a CPT code 99214 of $260. That's the first line item. 99214, $260. The patient paid us a copay of $20, which left a balance of $240. We got a payment of $240. And so now the patient's balance is zero. Now this is a dream world because we're not charging $260 and getting all this money, because we are operating today on what is known as a discounted fee for service. So when these payers negotiate with the providers to care for a certain population of patients, they are negotiating with each and every insurance company what they're going to pay for each and every CPT code. So then we have, for the same patient, CPT code 99213, and these are office visits. And if you figured it out, the 99214 pays more than the 99213. That means the patient is a little sicker or has more problems. So same thing, we charge $190. So they had a balance of $190. Patient paid $20, that left a balance of $170, and the insurance company paid it all. So this is an example of like a patient ledger. This captures what was charged, what happened for each and every date of service. And so when we submit a claim form to the insurance company, which we'll talk about tomorrow, the insurance company sends us back a piece of paper called a remittance advice. A remittance advice is like a check stub because it's got a check attached to it. Now, of course, because it's 2021, generally what happens is the check gets deposited into our checking account, but we take that remittance advice and we apply the payments to the patient's account to zero it out. And that zero out process could be, we have a part we have to write off, but it also is a part where we may have to mail the patient a statement to collect certain dollar amounts. Now, believe it or not, as it relates to co-payments, those dollar amounts are actually monies that we are supposed to collect at the time of service. We should not be billing a patient for a copay. And I'm going to tell you why. If you got to bill a patient for a copay, number one, you need an envelope. Number two, you need a stamp. Number three, you need the paper statement. So you need paper and you need ink to then put this in the envelope and mail it off. And hopefully the people at the front desk got the right address. Hopefully the patient will open it up and look at it and go online and pay us. So when the insurance company sends us the remittance advice, simultaneously, they're sending the patient what is known as an explanation of benefits. And at the top, it says, and I got an example right here. Somewhere on here, this is not a bill. And it tells you, you may, so wait a minute. Let me cover up my home address. I don't want y'all showing up at my house. But it says explanation of benefits. So this is what comes to the patient. And it tells you, oh, I can show you this part. It shows the amount that was billed. And it also shows me the amount that I may have to pay. Yeah, some of y'all wear glasses in this field. You can't be cute. You got to put your glasses on so you can see the words on the paper. So we get the remittance advice. The patient gets the explanation of benefits around the same time. So theoretically, the patient should be expecting that we're going to send them a bill. But let's just be real. ComEd. Yeah, I probably need that to keep my lights on. Comcast. Yeah, I need that to keep them kids quiet so they can play them video games. Dr. Bill, you ain't make the cut this month, so we put it in a pile, and that's how we have to keep sending the statements out. So the copay, we got to collect at the time of service because number one, our contract says that we will do that. All right, so you notice here for each and every CPT code, we have a dollar amount. On an annual basis, Medicare tells us which CPT codes or HCPCS codes they will pay for and how much they will pay for it. And it is based on a system called the resource. You don't have to write this down right now because it's going to be on my next slide. The resource-based relative value scale. So these are actually CPT codes, and this code actually here was deleted January or December 31st, 2020. And so these are here, new patient codes, and then these are established patient codes, and it's for patients that are in the office. And as we go from one level to the next, the reimbursement is different. And you saw that on the previous slide because 99213 paid less than 99214. All right, so every year, Medicare uses a mathematical calculation to determine how much they're going to pay us for each and every CPT and HCPCS code that they pay for. And they do this via what is known as a fee schedule. So first, there is a mathematical formula, and it looks a little intimidating, but this is a mathematical formula for the resource-based relative value scale. So I'm going to give you a moment to write this down, and then we're going to end today on an example. Because this is, I don't know about you, but I don't like math. So after I see a math problem, I need to take a nap. And I'm going to tell you what all of these different abbreviations and all of that means. So for right now, I just want you to write down the formula. Okay, so for every CPT code that Medicare, CPT or HCPCS code that Medicare reimburses for, they reimburse based on the resource-based relative value scale. And so this is the formula that they use, where they take into consideration for each and every service, the work that's involved, the practice expense that is associated with that service, and then the professional liability insurance. So the work, the practice expense, and then the professional liability insurance. So for example, the professional liability insurance, the work and the overhead for an anesthesiologist is going to be different than an office visit, right? Because if you're putting somebody to sleep, there's a certain level of liability associated with making sure that they get back up, right? The work, the practice expense, and the liability for a surgery is higher than an office visit. They also take into consideration where that doctor is practicing. Cook County versus Carbondale, Illinois. There's a difference. Anybody know why or how? So in Chicago, it costs more to live than it does in Carbondale. Rent is cheaper, things are generally cheaper. So when we talk about New York versus Chicago, which one is more expensive?
Possibly New York.
New York.
New
Yeah.
York.
Definitely New York. California versus Illinois.
I would say
California.
California.
Cali.
California.
Yeah, so certain areas of the country, the reimbursement for a CPT code is going to be higher or lower based upon the geographic location. So in this formula, Medicare considers the work, the practice expense, the professional liability insurance, and the geographic location of that doctor where they're practicing. Everybody still following me? So you've seen code 99213, and I'm going to show you an example after I tell you one more thing. So what happens is Medicare has what are known as relative value units. These are numbers. And basically, there is a work relative value unit, and there is a work geographic practice cost indice. Let me put that in the chat. Make sure I spell it right. So geographic practice cost indice, and we call it a gypsy. And the gypsy is the part in the formula where they take into consideration where that doctor is practicing. But when we talk about the work relative value unit, the practice expense relative value unit, the professional liability relative value unit, those are going to be the same for everybody across the country. But what may change their reimbursement is the gypsy. Then We take these numbers, we do some multiplication and some adding, and we multiply it by this other number, which is called a conversion factor. And the conversion factor is a number that Medicare establishes every year. And let me just look on my other computer. I want to see, I'm pretty sure that the conversion factor went down this year. Yeah, so the conversion factor from 2020 to 2021 went down. Why do you think it went down?
COVID?
Yeah, because of COVID. So that means that to some extent, and the internet is saying it was a 3%. Well, I'm seeing different articles. So every year it changes. Sometimes it stays the same. So here is an example. This is the last thing we're going to look at because this is a whole lot. So here's an example of calculating 99213, which is a CPT code. And so you'll notice there's the work, the practice expense, and the professional liability. And then there's a column for the RVU, and then there's a column for the gypsy. So we take the work RVU and we multiply it by the work gypsy. We take the practice expense RVU and we multiply it by the practice expense gypsy. We take the professional liability insurance RVU and we multiply it by the professional liability insurance gypsy. And then the result, the end result, are these three numbers here. We add up those three numbers and we multiply it by the conversion factor, and that gives us the reimbursement for the CPT code. Now, not to worry, you probably won't have too much of this on your CMAA exam, but you at least need to be familiar with it. So when they ask you questions about it, it'll make sense. And again, once we're done, you're going to go into kind of this review phase where you're going to be in an NHA system. You're going to do some review modules. You're going to do some practice questions. And so everything that we're talking about, you're going to see it in those systems along with practice questions and all of that. And of course, I'm going to give you some questions along the way. So there was something else I wanted to tell you about this. We don't have to calculate this in the real world. In the real world, the computer does it. But we have to understand how it is calculated, because if there's an error, you don't know if it's an error unless you know how to calculate it. Make sense? All right, so we are leaving off here. Tomorrow, we will pick up by continuing to talk about some more, let's call it bookkeeping aspects of the medical office. And then we will go into our compliance portion of our course. All right, that was fun. Questions?
A lot to go over.
It was a lot, yes. So I will have the recording up on the YouTube channel probably by 5 o'clock before I leave the office for today. And so those of you who didn't have a chance to listen to the recording from yesterday, you should probably go do, you know, both so that you'll be all caught up. All right. Well, everybody have a good afternoon. I'll see you tomorrow.
All right. See you tomorrow.
All right,
Thank
see
you.
tomorrow.
Bye-bye.
Bye.
Thank you. Same to you.
Yep.